about the heart. Don't forget, we need to have a healthy heart because yes, the cardiovascular system is a closed circuit, but the pressure to push the blood and whatever is in the blood to get to your pinky toes and even to go to your brain, it all depends on that main pump, which is your heart. The aorta will try to maintain that pressure, but that pressure came from the heart. And so that's why it's very important to appreciate and to keep maintain a healthy heart. And remember that there's two parts to the study of the heart. Okay, don't forget that there's the con- conducting part and the contracting part. So one more time, let's remember. If I'm going to if I was going to switch, I'm sorry. In the past, there was always a picture of the cardiac cycle. And I would ask students, please show me where the first heart sound is, the second heart sound is, the P wave, the QRS, where is the systole, the ventricular ejection, etc., etc. So you should know that the smaller waves, that's the atria has smaller pressure because it only has to pump from the atrium to the ventricle. So it's smaller. These bigger waves, that's the ventricle. And this one is ventricular volume. So there's only what? How many waves is here? One, two, three. This is the aorta, which I usually don't ask. That's for the next lecture test. Did I include I included the blood vessels, I think. But for the cardiac cycle, I want you to concentrate on the EKG, the ventricle pressure. This is the aorta, the heart sounds, and this is the volume. Then this one shows you what's going on in the heart. So we always start with all the valves being closed. You start with all the valves closed. So all valves closed. They're all closed. And then there will be a P wave. Number one, there's a P wave where there's atrial depolarization. So the atria gets depolarized right here. And you know that after you depolarize the atria, so this is the pacemaker of the heart. When you depolarize the atria, the result is the atria will contract, atrial systole. So first, what happens after the atria contracts? The pressure in the atria, the green one, it goes up. It will go up uh, to raise the pressure enough. So you see this brown one. When the pressure goes up to the point where it's enough to open the AV valves, it opens. So then finally, the AV valves open and the blood moves from here, from the atria to the ventricles. That is why, look at what happened. When the atria contracted right here, the brown one, the blood is moved from here to here. So we look at the ventricular volume. So the volume of the blood went to the ventricle, so it went up. In the meantime, your uh, pacemaker, it keeps moving. There's a delay. Why is there a delay? Because of the cardiac skeleton, right? I said there's three main functions of the cardiac skeleton. But the most important to me, so it serves as insertion, anchor, but the most important is it insulates. So because of the cardiac skeleton, there is a delay in that pacemaker. And that's very important. You want to empty the blood first from the atria to the ventricle so that by the time the ventricle contracts, there is blood to push out. So the QRS results in ventricular depolarization, and after the ventricle depolarizes, it will contract. The first type of contraction is called isovolumetric contraction. When the ventricle gets depolarized, the ventricle contracts, And now I'm going to look at the ventricular pressure right here, the blue one. So the ventricle pressure goes up. But when it goes up, the first thing that happens, I'm going to look at this one. The blood went from here to here. Then it contracts. The blood, the turbulence of the blood will push these valves, the AV valves. The first thing that happens, it will push it close, back up like that. So it will close it. And that's what you hear as your first heart sound. See? So, and then the pressure keeps going up. See, pressure will keep going up until it reaches a point where it's able to open your semilunar valves. So the blood then moves not back there but up there. So the pressure goes up. The sequence of the increase of pressure, it will go up first to be able to close your AV valves. That's what your as your S1. And then it will still keep rising, rising, rising until you're able to open another valve, the semilunar valves. So that's how the blood leaves your ventricle to go to the pulmonary artery or the aorta. Pulmonary artery on the right side, the aorta on the left side. Remember, the blood is effectively separated. Right side is effectively separated from the left side. Right side goes, all of it goes to the lungs. Left side, all of it goes to your systemic. So look, when this semilunar valves open, the blood is able to leave my ventricles. And so what happens is the volume of the blood left my ventricles. Where is it now? It's in the pulmonary arteries or the aorta. So the volume goes down. And when we trace that up here, at that point, the ventricles will repolarize. This is relaxation, the T wave. So when it relaxes, it goes to diastole. So when it goes through diastole, isovolumetric relaxation, the ventricles, the volume doesn't change because all the valves are closed. Again, how did the semilunar valves close? So these arteries, we're going to study them next. Arteries are unique because they have the wall of arteries have a layer of elastic fibers. It's called elastic lamina. In fact, it's two layers. So you remember that elastic fibers, what happens to elastic fibers? They expand like that. Then after they expand, remember they're receiving all of the blood from here to here. So they expand, and after they expand, what happens to elastic fibers? They go back to their original shape. So when they go back, can you picture in your head? When they go back, there's like a rebound of the blood. The blood moved from here to here, but there'll be some rebound of the blood back down there. When this one, when the elastic arteries contract, the blood will go back. But when it goes back, what it produces, it closes the semilunar valves. So at that point, this is closed and this is closed. Remember, it closed during systole. So when it relaxes, the ventricle relaxes, it will relax with all the valves closed. That's why you say isovolumetric relaxation. And you trace that. See, always look at where the compartment is located. All the way. So the pressure is going down and the valves are closed. And that's what you hear as the second heart sound. The second heart sound is because of the closure. Which valves close? The semilunar valves. The first heart sound is what you hear when your AV valves closed. When the semilunar valves close next because of the elastic recoil, you hear it as the second heart sound. So this is now relaxed, the ventricle is relaxed. When the ventricle is relaxed, the pressure is going down. Then you have another round of EKG. So the P wave again starts, you depolarize, increase enough pressure to open it, and you start it all over again. You start the cycle all over again. So the one thing you want to really look for here is this P wave, the EKG, this ventricular pressure. Just remember that the larger one is so this part here is pressure, this part here is volume. Pressure, volume, EKG, heart sounds. So in the test, if I say, where is the, let's say, isovolumetric or the end diastolic volume, stroke volume. So you look for that here. Where's the ventricular pressure? Look for that here. Then the EKG, of course, there. And then the sound waves. You can also use this one. That once you look at your cardiac cycle that way, first you look at this with this one. Then you look at this with this. Then this with this. Then you look at the whole picture. It's not going to be hard. In the beginning, like I said, in the beginning, it looks scary. If you want to do well in your test, lecture test number 2, one of my students, if you bought your book brand new, there's that Mastering A&P. You go to PAL, Practice Anatomy Lab, and you click on the cardiac cycle. A few of my students said that helped them tremendously in taking their lecture test number 2. But this one, like I said, once you maybe spend 2 or 3 times reading it and trying to correlate the events, you'll do well. Okay? And then the inotropic, chronotropic, there will be a section in your lecture test where you were asked, please tell me whether the following exerts a chronotropic or an inotropic effect, and is it positive or negative effect. You will also be asked to compute for the cardiac output. So remember, cardiac output, there's 2 values there, heart rate and the volume, the stroke volume. So just remember, cardiac output equals heart rate times stroke volume. If you know that formula, you can come up with the answer if I ask you to compute. You will also be asked to give factors that affect the preload, the contractility, and the afterload of the heart. So, I remember in the past they were asked to give examples of this one that affects the preload, contractility, and the afterload, and then discuss. So just remember that we're talking about the heart. So there's several factors that affect the health of this heart. One is what goes into it. And what returns blood back into the heart is a vein, venous return. And another factor that affects the cardiac output. So we're just talking about cardiac output. What are the factors that will affect this property of the heart, how it can work? So the things that will be returned to it, and then maybe the output part. So what returns blood to the heart is vein. What receives the blood from the heart is artery. So the output part is this one, artery related. The preload part is vein related. So preload means going in. After is going out. If you remember that, then I don't think you'll have a problem answering the section. And then contractility means the heart itself. So let's come up with some examples for contractility. What example can you write? Maybe MI. Are you familiar with this term? Myocardial infarction or heart attack. So You can use that as an example. Doesn't it affect the contractility of the heart? So you will, and then you're going to explain what do you think will it do. So if you have a weak heart, maybe it will affect the output, right? It won't be able to pump enough blood. These are the patients that you maybe give beta blockers, or you can even give them antihypertensive medications because you want to make sure the heart is already weak. If it's weak and the patient is hypertensive, then you're going to make it even weaker. You give them hypertensive medications to help the health of the heart. What are we going to write for afterload? Afterload, meaning this one. Afterload is output. Maybe you can write, are you familiar with the term arteriosclerosis? Meaning hardening of the artery. You can even write anything that's related to the artery. You can write cholesterol plaque, and then just predict what will happen. I predict that if there's a cholesterol plaque here, there's going to be increased resistance for the heart. That's how the heart may enlarge. And that's the one thing we don't like to happen with the heart, right? When the heart enlarges, it enlarges inside. It's like it implodes instead of explode. And when the heart implodes, the space inside gets smaller and smaller. What are we going to write for preload? Preload. Volume overload, right? So if you drink too much water, that's the scare. There's going to be an overload of volume over here. Okay? So the heart, as far as the preload is concerned, you should remember this Frank Starling law of the heart. Why do we worry? We said that the heart receives blood. Why do we worry? Why do we want to control the amount of blood that enters your heart? We know that any muscle, do you remember with with skeletal muscle when we were talking about muscle physiology? You remember that the elastic fibers in muscle, you remember when talking about muscle contraction, I said contraction is an active process, but relaxation is passive. Remember that? So the elastic fibers in muscle helps in the relaxation of muscle. So there are elastic fibers in muscle. That's part of the connective tissue of muscle. So the same thing with your cardiac muscle. We have elastic fibers here. So with preload, if there is an increase in volume that enters the heart can accommodate that because of the presence of elastic fibers. It can expand, but it can accommodate it to a certain extent only. Only to a certain extent. According to the Frank Starling law of the heart can expand to accommodate increasing volume to a certain extent. Why? Remember the zone of overlap. So when the heart stretches way too much because there's a lot of volume and there's no more zone of overlap, can that heart contract? It cannot anymore. That's the Frank Starling law of the heart. And this is why we have to control the volume. There's so many things that we have to consider as far as the heart is concerned. Control the preload, control the afterload, so that the heart will be able to do its job very, very effectively. Okay, so now we talked about the autorhythmic property of the heart. The heart beats on its own. However, the nervous system and the endocrine system, these two body systems modify. It can modify the activity of the heart. I remember. There was a question in the final exam, I think, true or false, or even in your lecture test. The endocrine system does not have anything to do with the fundamental beating of the heart. That's true. Same with the nervous system. It does not have anything to do with the fundamental beating of the heart. The rate and the rhythm of the heart is entirely a function of the heart itself. The heart has its own nervous network. But look at this one. Look at where you have baroreceptors and chemoreceptors. It's strategically located immediately right there in the aorta, the aortic arch. You have baroreceptors and you also have chemoreceptors. What do chemoreceptors monitor? There are two chemicals, right? Either oxygen or carbon dioxide. Which of the two do you think will be monitored by the chemoreceptors right here? Carbon, very good. Carbon dioxide, very good. If it's oxygen, don't forget, okay, oxygen levels, it's not the heart that respond, it's the lungs. Oh, no, 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 no. Oxygen levels, it's the blood. Sorry, the blood, the red blood cells. So this one, your chemoreceptors monitor carbon dioxide level. Okay? So if the heart pumps blood that is very high in carbon dioxide, what will happen is it will, see, the brain now will try to regulate the heart rate. It will make it beat faster so that you're able to deliver that blood quicker to your lungs so you can get rid of it. Does it make sense? Okay. How about baroreceptors? Of course, you know it monitors blood pressure. So if the heart pumps a lot of blood and the pressure is high, what do you think will result? So you have baroreceptors monitored by your brain. It will tell the heart to pump slower. Slower. So increase, remember that pressure as a volume times heart rate equals cardiac output. And so, if there's increased pressure, in general, that's because of increased stroke volume. So, to maintain cardiac output, we want to maintain cardiac output as much as possible. So, the two variables that you can adjust, the stroke volume, which is regulated by pressure, and the heart rate, which is monitored by your chemoreceptors. And that's where your nervous system comes into play. Another body system that helps is your endocrine system. So for now, we studied a few hormones, right? You think antidiuretic hormone can help, right? Aldosterone can help. There's another hormone now that you will add to your list of hormones. Atrial natriuretic peptide, or ANP. Some books write atrial natriuretic hormone. So they're one and the same. Okay. So this hormone, the goal is to lower the blood volume or the blood pressure. Where do you think, it's so obvious, right? Just by the word itself, atrial natriuretic peptide. Where do you think this hormone is made? Yes, very good. In the atria of the heart. So picture, if the heart is receiving a large volume of blood, do you agree if there's a large volume of blood that enters your atria, the atria stretches, right? And the stretching of the atria results in the cells of the atria secreting this hormone. Where is this going to go? It will, very good. It will go to the kidneys. It will tell the kidneys to release a large volume of salt, and along with salt, we know that water follows. That's how you control the volume. That's how you correct so that the heart doesn't enlarge too much. The thing about the heart, like I said, it cannot, there is no space for enlargement. It is very limited by that pericardium. So that it makes sense that the atria secretes this hormone, this atrial natriuretic peptide. Okay? You have any questions on the heart? How about the EKG? Do you have any questions on EKG? I will give you take home worksheets on EKG. Oh, write down this magic number, by the way. I forgot. 300, 150, 100, 75, 60. So in the test, I usually ask students to estimate the heart rate of the patient using an EKG strip. So when you're given an EKG strip, what you want to do is to locate two like peaks or waves. So you can use this one and this one or this one, and you just locate two like points. And then you see the large boxes, you see the dark boxes. You count the number of dark boxes in between those 2 points. If there's only one box between the 2 points, then the heart rate is 300. This is just an estimate. If there's two boxes, heart rate is about 150. Three boxes, 100. Four is 75. And then five boxes is 60. Okay? So that's just an estimate. Of course, now the EKG readings, you do the strip, it gives you the heart rate also. But if you're given, a blank like this, you can still guess. Of course, this one, you don't know the heart rate because this patient, you need to defibrillate. You understand when you need a defibrillator. What does it mean by fibrillating? It's not actually, there's no actual rate, there's no regular, it's like going through tremors. And we don't want tremors. It's not going to pump the blood. And I think we did discuss why VFib is more dangerous than AFib. So if I ask you to give me, to identify or describe what you see or your interpretation, I think that's your worksheet. It says interpret. You don't have to give me fancy terms. You just say, I don't see. Absent, you can even use arrows. P wave is absent here. QRS is absent. So if there is an absence of the wave, any wave, immediately your answer will be a block. There's a blockage somewhere. You heard of transient ischemic attack? A transient ischemic attack is a patient who complains of cardiac pain, right? And you know that what do they call that? Mini heart attacks? I think that's what they say in the ER. You had a mini heart attack. That's a transient ischemic attack. And this is very, very common with high cholesterol. So people with a plaque somewhere or a clot somewhere, what happened was that cholesterol plaque was dislodged, and you know that blood vessels become smaller and smaller. And so by the time it got to the heart, there was a blockage. And at that point that there was a blockage, the patient experienced heart pain. When you did the EKG, there was a blockage, so you see that there's a block. But then you continue the EKG strip. After a while, it becomes normal again. So that's when you say that the patient had a mini heart attack, transient ischemic attack. So you're going to tell the patient you must have had a plaque or a clot. So these are the patients that you send for a Doppler. So you look at the what do you call this? What do you call it? What do you call that? The lumen, the blood vessel inside. What do you call? Inside the blood vessel, you're looking at if there's any clog inside. What do you, a Doppler? But you're looking at, huh,
You're looking at it like you're looking at like a
you're
pipe.
looking at the internal, what do you call it? What? The lumen. You understand what I'm talking about, right? So the hose, the blood vessel, when you send the patient for Doppler, what they're looking at is the inside, the lumen inside. They're trying to see if there's any more plaque that's left there. So you tell them they take cholesterol lowering drugs. See, that's the thing about cholesterol. Remember, you cannot lower your cholesterol by exercise. The only way to lower your cholesterol is by watching your diet, number one, and drugs. That's it. And that cholesterol is that the pain in the butt. It can cause a blockage. You understand? Okay? So, do you think you got this? You think you got the heart? Do we have anything? Let me see. It's not really that hard. Oh, one thing about coronary circulation, by the way. Coronary circulation. I'm not very particular with memorizing the different blood vessels. What I want you to appreciate, you have two major arteries. An artery is it's a blood vessel that delivers blood to the rest of the body. So, by the way, don't forget, no, we're going to talk about that in the next chapter. So, the coronary circulation is the blood that supplies nutrients to the heart itself. The heart is made up of muscle cells. You know that it works hard, it's never ending, pumping, right? So that means it needs to be supplied with nutrients. You remember I told you that the main nutrient, that the preferred nutrient for that is what? Fat, very good. That's why we want to make sure that we always have the good fat right here in our belly. Okay? So, and look at this one. The way it delivers the blood, the nutrients to the heart is called coronary circulation. The good news about the heart, the coronary circulation, you have a right and a left. Right coronary artery and left coronary artery. And they meet. There's collateral circulation. They form one circle. So the right, it it uh, it 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 supplies the anterior part of the heart, and the base part of the heart is generally supplied by the left. But there's collateral circulation, and that's the good news. Although it's good and bad because especially with the guys, they feel some pain here. They think it's just indigestion, or maybe they think it was just too much, maybe cutting, whatever, chopping wood. They don't realize it may already be a transient ischemic attack. Okay, but that's a godsend where you have collateral circulation. So that means that even if my right coronary artery has a blockage, as long as the left is still uh, good flow, the whole heart will still be able to be nourished. That's the good news. Another part of the body, you see, the very important parts of the body, the heart and the brain. The brain has the same thing. At the base of the brain is called the circle of Willis. I think that was asked in your worksheet, which I'm going to ask you to give to me, okay? There's at the base of the brain, see here, You familiar with the carotid arteries right here?
Mhm.
In the back, it's called vertebral artery. Makes sense, right? Vertebral artery, carotid artery. They meet right here at the base of the brain and they form a circle called circle of Willis. It's the same principle. So that if you have carotid blockage, which a lot of times we will have, no, not all of us, but a lot of people with, cholesterol problems, there's blockage here. Even if it's blocked, as long as the vertebral arteries have good flow, your brain will be nourished. See how much God loves us? Brain and heart has that collateral circulation. Okay? So you understand all of that? No problem. Do you understand calcium induced calcium release? You appreciate the importance of that one? And I told you that's why we have all of this calcium bank from your skull all the way to your phalanges. You have calcium stored here all the time. And you have your parathyroid and your calcitonin hormones making sure that the calcium in the blood is always normal so that the heart will still be able to pump normally at the expense of the health of your heart. You understand that calcium induced calcium release, right? You need to know this one, your pacemaker, where it starts in the SA node. So, why is the SA node the main pacemaker? There's a difference in the rate of firing of different parts of your pacemaker. The SA node fires the fastest. This is about 300 times a minute it fires. But this one right here, by the time you get down here, it slows down. This one they say is about 40 times a minute. So average that out. Your regular heart rate is about what? 80, 70, 80, 90 beats a minute because it averages out. So that's why I can tell, you can guess or predict where in the heart is the problem of the patient. So patient comes in, you suspect there's irregularity in heart rate, regular EKG readings, and you check the heart rate. If the heart, and you compare that with the previous notes of medical history of your patient, you look at the previous heart rate during physical exam was 80. Now the patient comes in, abnormal EKG tracing, and then heart rate, you notice it's slower. It's like 60 beats a minute, maybe 50 beats a minute. So I'm thinking that the problem of the patient, do you agree, is somewhere here. There is an infarct or some dead tissue here, so that the heart rate now or the pacemaker is taken over by this one right here. This is slower in firing, and it makes sense that the heart rate now is slower. Do you understand? Okay, so maybe you will be given some clinical scenario in your lecture test, and I'm going to say, can you guess or predict where in the heart could possibly be the problem of this patient? So you're going to look at everything. You look at, oh, there's abnormal EKG. Look at the heart rate. If the heart rate is still normal, then I'm thinking maybe the problem of the individual may be in the ventricle. That's how you're able to guess. It's just a guess. Then you send the patient for further EKG, further echocardiogram tests, further testing. But at least you have a working diagnosis that will help you in requesting for follow-up testings. Okay? What else? So, no, master the blood vessels. No, I want it to be the blood, and you just discuss. Oh, I'm going to enter the right atrium now, from right atrium to right AV valve, right AV to right ventricle, to the pulmonary artery to the lungs. Okay, and then when it gets to the lungs, it picks up oxygen. So this is really what happens, okay? So this, you're going to open up your sheep heart today, okay? I want you to use probes. So every one of you should have probes so that you can trace the flow of blood and look for openings. By the way, as far as the superior and inferior vena cava is concerned, you're not going to look for two openings in the atria. It's just one opening, and it's really like this. Okay. So there's blood from the superior vena cava, blood from the inferior vena cava, returning the heart to the right atrium. So this blood from the superior vena cava and inferior vena cava, it's deoxygenated blood, meaning it's high in carbon dioxide, low in oxygen. So that's what's entering my right atrium. From right atrium to right AV valve to right ventricle. And the right ventricle will pump that blood away to the lungs. So this blood delivering blood, this blood vessel leaving the heart is an artery. Because it's going to the lungs, it's called pulmonary artery. You need to know your anatomy. So here, what's going on in the lungs? The blood is going to unload the carbon dioxide and you breathe it out, and it's going to receive oxygen. So then oxygenated blood will be returned to the left side of the heart. What returns blood to the heart is a vein. This is coming from the lungs. You call this pulmonary vein. Don't forget this. In the past, it was a common practice to describe or define a vein as a blood vessel carrying deoxygenated blood, but that's not true. All books on A&P now define veins as delivering blood back to the heart. Because, don't forget for your test, okay? The pulmonary vein carries oxygenated blood. It carries oxygen-rich blood. The superior and inferior vena cava, they carry oxygen-poor blood. So this one going to return to the left atrium, then left AV valve, then left ventricle, then aorta, pumping blood away from the heart, going to the rest of the body. So this is oxygen-rich blood. So this is your first drawing, like this one right here. This is one of the best drawings I have received. See? And she wrote notes. So that's the first part of your drawing. And now you know that one. And then when we study our digestive system, renal system, and respiratory system, you will include that in your drawing. This definition, oxygenated blood, you're going to add to that definition or description. Here you're going to write it's loaded with urea, loaded with waste products, then but nutrient-rich blood. You're going to add that to your description by the time you're done with A&P. So you'll come up with these nice drawings. And you'll be done with your A&P having been very confident that you know everything that's going on. And in fact, some of my students also included in their drawing the muscle. They included the lymph. It's amazing. Okay? You have any questions on this chapter? I think you're good. Don't overload your brain cells too much. Okay? Just, it's better to know the basic and know it very well than trying to know all of the other details and just skim through it. Do you understand? You think you're good? You build your confidence for the lecture test? I will give you take-home worksheets for to be due next week, next Wednesday.
The next lecture test is on chapter 15.
The next lecture test will be heart and blood vessels. Let me check. I think it's hard. And it will be the same thing as your critical thinking. There will be a lot of critical thinking in your lecture test.